Again, it's grand rounds and a return engagement with Dr. Mark Banaka. And Dr. Banaka has a BA, cum laude from Bucknell. His MD is from the University of Connecticut. He has a master's in public health from Harvard School of Public Health, now Chan School. His internship and residencies, he's a Boston faithful at Brigham and Women's. He is an assistant professor of medicine at Harvard Medical School, the medical director of the acute aortic syndrome program at Brigham and Women's. He is associate editor of Circulation and has many articles of his own, has many honors and awards, is a well-received and well-distributed speaker, I might say, and to edify you on what's new and the very latest on lipids, Dr. Banaka.
All right, well, thank you. It's really a pleasure to be here today, and I want to recognize that, that not only is there an audience in this room, but I understand we're streaming in multiple locations, so I hope we can do some Q&A, and we'll use the microphones as we'll have a broad audience for that. So lipids, the latest lowdown. I'm giving this talk from two perspectives. One, I'm a clinical trialist, fortunate enough to work at the TIMI study group at the Brigham and Women's Hospital. I'm also a busy clinician, like many of you. I have a very busy clinic and some complex patients, and so, part of what we'll talk about is what we see from clinical trials, what's the latest lowdown. But part of it will be a little bit of a discussion of how do we apply some of this in our practice. Before I start, I want to acknowledge Mark Sabatine, who is the chairman of the TIMI study group, Bob Giuliano, who's a senior investigator, and Chris Cannon. Many of the slides you'll see here are slides that they have put together that I have shared with me, so I want to acknowledge their hard work, not only in leading the science, but also creating the slides. I also have several disclosures here, including Amgen and Merck, which make lipid-lowering therapies, as well as AstraZeneca. So just by way of background, I think it's important to recognize some of the history here that late in the 1850s or so, Dr. Virchow described lipid accumulation in the arterial walls in patients with disease. In 1913, there were animal experiments showing that if you fed rabbits cholesterol, they would develop atherosclerosis, not a normal disease state for rabbits, and we'll talk more about rabbits later. And then in the 1940s, Ansel Keys and the sort of epidemiology linking cholesterol to heart disease, followed by several epidemiologic studies. And then by the 1980s, there was sort of widespread academic agreement. And in 1985, an NIH statement saying that it's been established beyond reasonable doubt that lowering LDL will reduce the risk of heart attacks. And if we look at lipid lowering, if we look at where the adult American sits in terms of milligrams per deciliter of total cholesterol, we're much higher than domestic mammals, certainly wild mammals, and other populations that have different diets and exposures. And so are we really lowering LDL and cholesterol to very low levels? Is this a new thing, or are we trying to get back to what was a more natural sort of cholesterol? We know, and many of you all know this, that there have been many statin trials, and that in over 160,000 patients, if you use statins to lower LDL cholesterol, you reduce cardiovascular risk, right? So you reduce non-fatal MI, coronary heart disease death, coronary revascularization, ischemic stroke, and any major vascular event. And all of this comes with statin therapy with very good safety profile, without any real significant safety effects other than rare increases in rhabdomyolysis. And I think we all have patients that develop myalgias, but otherwise a fairly benign safety profile. Now, the data that I'm showing you here are all with statins. And so we know that LDL is a risk factor, and we know that lowering LDL with a statin reduces cardiovascular risk. And for a long time, really it was all about statins. And if you look here, here you can see in the yellow primary prevention, the blue secondary prevention. As we move to the left of the slide, as LDL cholesterol goes lower, event rates go down. The slope of the curves are different because secondary prevention patients are higher risk. And as we've achieved lower and lower LDLs with statins, we reduce risk. And of course, this was reflected in more recent guidelines that really were targeted in terms of intensity of statin therapy rather than other mechanisms of LDL lowering, because there was some paucity of data in terms of the effects of non-statin mechanisms. Of course, all of that has changed over the last few years. I'm going to show you here Prove It TIMI 22. I was a fellow when this trial came out, and Bob Giuliano was the attending in the coronary care unit, and that changed practice overnight. Every patient that was there with an acute syndrome got put on atorvastatin 80 milligrams, and so truly a practice-changing trial. We believed that we're really doing something important for our patients. We're reducing risk. But I think it's important to recognize that there was bad news too, right? So if you look at the Kaplan-Meier curves for Prove It TIMI 22, these were acute coronary syndrome patients followed for 30 months and randomized to pravastatin 40 milligrams or atorvastatin 80 milligrams. And you can see that here they had a median LDL of 95 milligrams per deciliter. That although there was a highly statistically significant 16% relative risk reduction, even in the treatment arm where we're giving atorvastatin 80 milligrams, look at the event rate here, right? That there's over 25% at 30 months are having recurrent cardiovascular events. And so I think it's not a binary thing. Although we think you're on a high-intensity statin, that's a good thing. We have to recognize that there's significant residual risk. And I'll point out, this is an analysis that a fellow of ours presented and is being submitted for publication. This is the Improve It trial, which I'm going to show you the design of. But these were ACS patients followed now for 7 years. 7 years. I showed you 30 months. Here's 7 years, acute coronary syndrome. These are the event rates over time, stratified by ACS alone, ACS with concomitant peripheral artery disease or diabetes, or ACS with a combination of both. And I want to make 2 points. First, we think that the highest risk is within the first year. Certainly, the steepest part of the curve is within the first year, but look at all of the risk that extends beyond the first year. The patients that look stable, they might be 2 or 3 years out from their ACS, are incredibly high risk. And if you look at the event rates here we're at an event rate of about 40%, here 60%. For these patients with PAD and diabetes that have a history of ACS, they're having event rates that are over 60%. These are the type of Kaplan-Meier curves we see in patients with malignancy. And I think that we have to recognize the residual risk that we walk into the clinic, and a lot of these are complicated patients, and they have a lot of comorbidities, and they're on a lot of pills, that they sometimes look stable, I feel fine, and we have to recognize that how they feel doesn't reflect the underlying disease state and the high risk that they face. So what about newer mechanisms? Well, I think you're all probably familiar with ezetimibe. It is a medication that inhibits cholesterol absorption. It sits in the brush border and reduces 54% less cholesterol is absorbed versus placebo in a clinical study. In terms of outcomes, this was really studied in the Improve It trial, which was a large trial of patients with acute coronary syndrome randomized to simvastatin 40 milligrams or the combination of ezetimibe with simvastatin, and then followed, I showed you the duration of almost 7 years. What's important to recognize here is that these were really well-treated patients. So even in the placebo arm, you can see that patients had an LDL cholesterol of less than 70. And that was the design of the trial. After Prove It, we knew that getting to 70 or below was a good target. And the idea here was, if we get them even lower, is that even better? And the second question is, if we do so with a non-statin therapy, will it make a difference? And so patients here went from 70 to 54. And sometimes in clinical practice, those differences may seem small. Is it 70 versus 54? You're on a high-intensity statin. Does that translate into benefits? And there was a significant reduction in risk with the addition of ezetimibe to simvastatin, with the number needed to treat of 56, albeit over 7 years. Now, ezetimibe is a fairly modest Modestly effective LDL lowering therapy is about a 20% reduction in LDL cholesterol, and in patients that are this low, starting at 70, the absolute risk reductions are more modest. But obviously if you have a patient with an LDL of 100, you're going to get a much more robust risk reduction. And so, IMPROVE IT was, I believe, a truly landmark trial. It established beyond a doubt that lowering LDL, even through a non-statin mechanism, would reduce risk, and that even lower was even better. And if you plot the benefit of IMPROVE IT on the regression line with all of the statin studies, and you look at this line of what you'd expect based on the achieved LDL cholesterol, it falls exactly on the line. So it does exactly the same thing in terms of risk reduction as a statin. Now this has been reflected in different guidelines. Here you can see that there is, in the ACC expert consensus, there's a comment here that ezetimibe is the first non-statin that should be considered, given its safety and tolerability. I didn't say that specifically, but there were virtually no side effects to ezetimibe seen in the IMPROVE IT trial. And then the ADA guidelines here now changed management. I showed you that diabetes curve. Here for patients with recent ACS and LDL cholesterol 50 or greater should be considered for the addition of ezetimibe, or if they're unable to tolerate a statin. So looking at a lower target already for patients with diabetes and ACS. What other mechanisms have been studied? Well, CETP inhibition was very exciting. The idea that we could raise HDL. There's, unlike LDL, where it's fairly clear it's a risk factor, HDL may be a risk marker in terms of beneficial, having higher HDL. No one really knows if raising HDL is beneficial. CETP was a mechanism where we would block transfer of cholesterol ester to LDL or VLDL, where it could go back to the artery and be atherogenic, and would make big HDL particles and raise HDL. So it was actually initially studied for HDL raising, and the first drug that went into studies was torcetrapib, and of course that trial was stopped early for harm. It also does lower LDL cholesterol. And there were three compounds that have been studied. The one that had the largest outcomes trial was the REVEAL trial, and this was led by the Oxford group along with TIMI, and it was a drug anacetrapib. And I think what's important to recognize is that not only did it raise HDL, but it actually significantly reduced LDL cholesterol. And this was recently presented. This was effective in reducing cardiovascular risk in over 30,000 patients with stable atherosclerotic vascular disease. And we see a typical trend here in terms of the efficacy, that there's relatively modest effect in the first year or two of exposure, but it was really the third and fourth years where you see the most benefit, and there was about a 10% relative risk reduction. So here we see again that lowering LDL cholesterol now through a different mechanism, not cholesterol absorption or statin, but here CETP inhibition was effective. Now this therapy won't be commercialized, but it does give us more insight in terms of the mechanism. More recently, a lot of the excitement has been around a class of drugs called the PCSK9 inhibitors. PCSK9 stands for proprotein convertase type 9. PCSK9. So I won't say that again. But it is PCSK9. This is a chaperone protein. It chaperones the LDL receptor complex with LDL cholesterol to the endosome for destruction. We want LDL receptors. Statins increase the expression of LDL receptors. They sit on the liver and they pull LDL cholesterol out of the circulation. More PCSK9 around chaperones more for destruction, so you end up with less LDL receptors. Now, this is a quite elegant story that was first developed, I believe actually it was in Montreal, where they looked at some families, some that had high PCSK9, some with low PCSK9, and they saw different associations with cardiovascular risk. And there are some patients that have loss of function mutations in PCSK9 where it doesn't work, where they have very low LDL cholesterols and they appear healthy and have lower cardiovascular risk. So there are several compounds. I'm going to talk about two of them. One is evolocumab, which is a fully human monoclonal antibody which blocks PCSK9. It lowers LDL cholesterol by about 60%, and is safe and well tolerated. There were early exploratory data that suggested that it reduced cardiovascular risk. So the landmark trial that really established the efficacy of evolocumab was the Fourier trial, and this was over 27,000 patients. These were stable outpatients, probably like many of the patients that you see in clinic, prior myocardial infarction, prior stroke or peripheral artery disease, or some combination of the three. They were put on lipid stabilization, they had a placebo run-in, and then they were put on statin therapy plus or minus ezetimibe. And they had to have an LDL cholesterol of 70 or a non-HDL of greater than or equal to 100, and then randomized to evolocumab or placebo. This is an injection therapy. How many of you prescribed evolocumab or PCSK9 inhibitor? So just a couple of hands in the audience, okay? Well, this was the effect on lipids. You can see that these high-risk patients had placebo LDL cholesterol around 90. And there was about a 60% reduction to 56 milligrams, 30 milligrams per deciliter. So about a 56 milligram per deciliter reduction. So a very potent reduction. And it's important to see that this was stable over time. There was another compound, bococizumab, that was not fully human, but a humanized antibody. This was presented by Paul Richter in the SPIRE trials. That drug, because there were anti-drug antibodies that developed in some, the effect on LDL cholesterol waned over time, so the treatment curve kind of creeped up. But here you see with a fully human antibody, that's not an issue in all patients, or at least on average there was a median of 30 milligrams per deciliter, which was persistent through the end of the trial. And that reduction reduced cardiovascular risk. So you can see here the primary endpoint of the trial, which was cardiovascular death, MI, stroke, or urgent angina, unstable angina, was reduced by 15%, and there was a 20% reduction in the more traditional sort of triple composite of hard endpoints, so CV death, MI, or stroke. So the trial was a positive trial. This therapy was effective. And I think the summary here really states how important the findings were. So that evolocumab reduced cardiovascular risk. The reduction in clinical risk was the same as we see with statins per milligram per deciliter. And getting LDL cholesterol less than 50 was beneficial. So PROVE-IT said 70, IMPROVE-IT said 50, and here we got people down to 30. And it was safe and well tolerated, and I'll show you some of the safety data. Now, it's important to recognize that when you look at different trials, there are two important things to recognize. One is what is the absolute reduction in LDL cholesterol, because that's what drives the benefit, but also what's the duration of benefit. So I showed you from REVEAL that with lipid-lowering therapy over the first 6 months to a year, there's a relatively modest reduction, and it's really after year one where you get the greatest benefit. And you can see here that if you look at all of the statin trials, and you line up the benefits in terms of the relative risk reduction in black, if you plot evolocumab starting at year 2, when you get a stable effect, they line right up, and you see the exact same benefit. And so that PCSK9 inhibition is as effective as statin in terms of the risk reduction per milligram per deciliter of lipid lowering. Now, of course, for our patients in the clinic, when we look at a Kaplan-Meier curve, we're looking at first events. For a patient in the clinic, we're looking at total events, right, with the totality of the data. So if they have a heart attack and a stroke prevented, you care about both, not just the first one. And when you look actually at the first events, which is what I showed you from the first bar graph, you can see if you add the additional events, there are many more events. And I think this is intuitive to those, to all of you that have a busy clinical practice, that these patients have recurrent events over time if you follow them long enough. And for the additional events beyond the first event, the effective therapy was as great or even greater. And you can see the total events, so that there was an actual difference in over 500 events between the groups. And that those recurrent events reduced were coronary revascularization, MI, and stroke. You see significant for all three. And so if you looked at the strategy of, you're going to translate Fourier into your clinical practice, if you took 1,000 patients and you treated them for 3 years, you would reduce the number of events by 22. So you prevent 22 CV death, MI, or stroke events. If you look at the total events, however, the true effect is much more robust because you're looking at the recurrent events as well, and these were analyses led by Savina Murphy and her group, and you would reduce by 52 events. So more than doubling of the actual benefit that you get if you look at the total number of events. So that was one lesson from the 4A trials, look at all of the events. A second lesson was, well, is there a plateau at which LDL reduction no longer translates into cardiovascular benefit? And we talked about 70, 50, and 30, but if you get people down even below 10, does that translate into risk reduction? Is it still beneficial? And this is a regression line here looking at the achieved LDL cholesterol at 4 weeks and then the event rate on the y-axis. And you can see here the adjusted hazard ratios for each of the bins. And you can see that this is a straight line, that there was no plateau. There's no point where we would say, well, you've hit an LDL 30, therefore getting lower than 30 is not beneficial. But there were patients down at very low levels, and the benefit was continuous. And I think the take-home from this slide is that there's really no safe level of LDL for a high-risk patient. If you can get them lower, practically, then it will be better for that patient in terms of risk. So I'm going to show you a few sensitivity analyses to illustrate this. So first, what about patients who started with an LDL cholesterol less than 70? Those are in green. So here you have to see the population for this primary endpoint at the top and the key secondary on the bottom. If you look at patients who started with an LDL less than 70, so patients that we generally would feel are well treated, right? They're on a high intensity statin with an LDL less than 70. Here you see that the benefits were exactly the same. There was no heterogeneity here versus patients that had a higher LDL. Now I'll show you data later from a more recent trial that suggests the greatest benefit is in patients that have a higher LDL. And of course that's true for the absolute risk reductions, but in terms of the relative benefit of therapy, it's consistent regardless of where you start. And it's regardless of whether you are on a high-intensity statin. So here's your patient on a maximum intensity statin. You can see that there's still a 14% reduction in the primary endpoint and a 22% reduction in the composite of CV death, MI, or stroke. So that patient who has an LDL less than 70 on high-intensity statin still derives benefit from getting their LDL even lower. Well, whenever we look at a trial like 4A, and I think those of you that are prescribed it know that there are some barriers to getting the drug. Sometimes in practice, getting it paid for is difficult. It can be costly. And so you might be looking for populations that are going to drive the greatest benefit. Who do you choose in the clinic from the wide variety of patients I talked about, prior MI, stroke, and so on? Well, patients with diabetes in several studies, certainly this was true in Improve It, but it's true here too. Patients with diabetes have much higher risk than those without. So in the placebo curve, a 12% event rate at 3 years versus 8%, so about a 50% increase. And the risk reduction was similar between the two, number needed to treat of about 50. But the absolute risk reductions are robust for both and statistically significant. So a higher risk population, both get benefit with and without diabetes, but clearly a higher event rate here. The effect is symmetric. There was, in the Improve It trial, there was a much greater benefit, an absolute benefit with ezetimibe in diabetics, although some of that had to do with other risk factors. Here we see more consistency. But I think the overall risk in this population is something to take home. The other is for the prior MI patients. We have done work in other studies and antiplatelet studies that show that not all MI patients are the same in terms of risk. And here Dr. Sabatine looked at several features that predicted greater risk in patients with prior MI. So these were patients that had more recent MI, so within 2 years, multiple prior MIs, at least 2, or multi-vessel coronary disease. And if you looked at patients that had at least one of those features, here in the blue, you can see a much higher event rate versus here in the light blue, the patients who didn't have one of those high-risk features. And you can see that there was a greater benefit, a 22% relative risk reduction and a 2.5% absolute risk reduction. So a number needed to treat less than 50. So patients with diabetes, patients who have a high-risk MI history, so multiple events, multivessel disease or recent MI, those are patients that may derive greater benefits from even more intensive LDL lowering. Then I want to talk a little bit about peripheral artery disease. Patients who have PAD, it's much more prevalent than we appreciate. Symptoms are often underreported because patients with PAD also have diabetes and their older age. They attribute their limb symptoms to their knee or their muscles or their statin or something like that. But even when we do recognize PAD, we can see that those patients are very high risk. And even after you adjust for all of the baseline differences, if you have peripheral artery disease, you are at a higher risk of major adverse cardiovascular events than if you had an MI or stroke without peripheral artery disease. There's about an 80% increase in risk. So that may seem counterintuitive, but somebody with limb disease actually is higher risk than someone with a myocardial infarction. But we recognize that patients with PAD also have coronary disease and stroke. And here I've stratified the group into three. Patients with MI or stroke and no peripheral artery disease. Patients here with PAD and no MI or stroke, and those that have polyvascular disease. And you can see even those patients that don't have any evident history of stroke or coronary disease are higher risk than patients without PAD. So there's a gradient of risk here. And the highest risk is in those with polyvascular disease. And this has been seen in multiple data sets. It also was the hypothesis underlying the COMPASS trial, which showed benefits of long-term therapy with a low-dose rivaroxaban. And so in your population, in your patient, in your clinics, I think you should definitely think about the polyvascular patient, the patient with PAD and coronary disease, the patient with PAD and prior stroke, as an extremely high-risk patient with a malignant vascular phenotype. In terms of the benefits of evolocumab here, we saw a slightly different pattern in terms of efficacy. You can see that the curves diverged very early. Risk was higher in those with PAD versus those without PAD. I showed you that already. And that there was a very robust absolute risk reduction in the primary endpoint. And this is actually the key secondary, this is the composite of CV death, MI, or stroke. And so in patients that have peripheral artery disease, the number needed to treat was only 29. And I think that was quite favorable relative to the overall trial, which had a good number needed to treat, but this is quite low, less than 30, and versus 72 in patients that didn't have PAD. Now, I talked about the polyvascular patient. What about those that just have PAD alone? Well, you can see that the benefits are entirely consistent, even if they don't have evident coronary disease or stroke. And here you can see there was a 4.8% absolute risk reduction in this population, a 43% relative risk reduction, and a number needed to treat of 21. And this is for CV death, MI, or stroke. So we're getting into very favorable number needed to treat numbers. You can see here that a risk of 5.5% in about 2.5 years is almost halving of the event rate. The other thing that I want to highlight is the consistency amongst all of the components of the primary endpoint, including stroke, where we saw a statistically significant robust reduction. We see this with ezetimibe as well, that LDL lowering has a potent effect on stroke, so it's not just coronary events. So major adverse limb events, this is the entire trial. We characterize them: acute limb ischemia, amputation, and urgent revascularization. You can see there was a continuous risk throughout the trial, and we saw a significant 42% relative risk reduction in major adverse limb events, and the effect was consistent for acute limb ischemia and amputation, ALI, major amputation, and urgent revascularization. So that the benefits of lipid lowering are not isolated to the coronaries, they're not isolated to stroke, but they translate to the limbs. And not as much work has been done with lipid lowering therapy and limb outcomes, but there was an important paper from the heart protection study in 2007, which showed that patients randomized to simvastatin versus placebo with PAD had reductions in limb outcomes. So this is not the first time this has been seen, but a much more robust reduction with evolocumab, and I think relevant to the population with PAD. And in fact, if you look at the patient with PAD, you can see that there's a higher event rate and a significant absolute risk reduction of over 1% in this population for limb outcomes. So another consideration. I showed you the regression line for major adverse cardiovascular events and LDL lowering, showing you that there was no sort of threshold or plateau, even as we achieve very low levels. Well, for the first time, we see that that's true for limb events too, that as we go from right to left on the slide to achieving even lower LDL cholesterols, our risk of having an adverse limb event continues to go down with a linear relationship. And so I think this is particularly important if you have patients with diabetes, PAD, or both in your clinic. When you're talking about the benefits of LDL lowering, it's not just with evolocumab, but with statins or ezetimibe, that the benefit extends beyond the coronaries, that if they're worried about limb risk, they should think about getting their LDL even lower. There are data now for antithrombotic therapies, for rivaroxaban, for antiplatelet therapy, and others. But remember, those come with a risk of bleeding. And here we have a therapy that is very safe, well tolerated, and has profound reductions here if you look at adverse limb events. So when you put all this together in the PAD patient and you look at the combination of adverse cardiovascular and limb risk in patients with peripheral artery disease, this is what you get. You get a number needed to treat of 25 and a 27% relative risk reduction. And if you look at those patients with PAD alone, walking into your clinic, what is the benefit of adding this injection therapy or high-intensity statin plus ezetimibe? You can see that there's a number needed to treat here, getting their LDL down to about 30 milligrams per deciliter of 16. So very favorable number needed to treat. So I think that this is a population that should be considered for very intensive lipid lowering. So what about the safety of doing all this? I alluded that it's very safe. Here we're looking at, based on achieved LDL from the purple to the red, purple being the lowest. We looked to see if there was any trend in serious adverse events, diabetes, cancer, cataracts. I'll tell you more about neurocognitive. There have been data suggesting a relationship with hemorrhagic stroke. There was no trend at all between the achieved LDL in the trial and any of these safety events, including elevations in liver events or CK as a marker of muscle injury. So no safety issues in general. And if you want to see those patients that achieve the lowest LDL cholesterol, so an LDL less than 10, median of 7 milligrams per deciliter, which I'll say that when this trial was designed, people were worried about the safety of that. You can see here the divergence in the curves over time in those that had an LDL less than 10 and a 41% relative risk reduction. So getting people that low was clearly beneficial. And this is a credit to Bob Giuliano. If you want to look at animals or mammals that have LDL cholesterols that low, you have to go to the New Zealand white rabbit, which is an animal model which doesn't develop atherosclerosis. So benefits in those that achieve very low levels. You can see here effective, and then safety. What is the safety of getting an LDL to 7 and following people for 2 or 3 years? There were no differences in adverse events or adverse events leading to drug discontinuation. So it appeared to be very safe to achieve LDL cholesterols that low. Bob Giuliano led a study called Ebbinghaus, which was nested within the Fourier trial and was focused on neurocognitive outcomes. There have been a lot of concern in the lay literature or in observational studies that statins and lipid lowering could increase the risk of cognitive dysfunction or dementia. And here, Ebbinghaus was one of the most intensive neurocognitive studies that I've ever been a part of, and it was nested within Fourier. And you can see here, using a battery of scores, patients baseline and post showed no differences in neurocognitive effects between placebo and evolocumab. Here are the changes, they're negligible. And you can see that for non-inferiority, saying, is the evolocumab worse for neurocognitive effect, there's no difference. So there was absolutely no difference, albeit over an exposure of about 3 years, in neurocognitive effects in patients receiving evolocumab. And this was a much more robust study than most of those that we do in cardiovascular outcomes trials. The other issue we think about with statins is new onset diabetes. We know that in patients that are at risk for diabetes, that statins may increase the risk of diabetes. So it's looked at here. You can see at each year of the trial, end of year 1, end of year 2, end of year 3, there was absolutely no relationship between evolocumab and the onset of diabetes. And if you look at the hazard ratio here, these are patients without diabetes. The hazard ratio is 1.05. And here, a high-risk population, those with pre-diabetes, those that are highest risk of translating, there was a hazard ratio of 1.0. So we don't see a risk of neurocognitive effects, we don't see a risk of muscle effects, we don't see a risk of diabetes. So what else has been explored? Well, just recently at the ACC was the Odyssey outcome trial. And Odyssey looked at another PCSK9 inhibitor, a fully human antibody called alurocumab. And this was a different population. So Fourier, everything I showed you, were stable patients with atherosclerosis. Odyssey looked at post-ACS patients between 1 and 12 months. Of course, some overlap between the two, but this is a more acute population, and randomized them to alurocumab or placebo. Here you can see lipid lowering. If you look at the on-treatment effect, again, very stable, just like Fourier. There was no effect of anti-drug antibodies on achieved LDL. And here they started with a bit of a higher baseline LDL cholesterol of around 90, but still got people down to about 30 or 40, ending at about 50. And here you see that 99% were on statin, 89% high-intensity statin, a few on ezetimibe. It was 19,000 patients. And for the primary endpoint of MACE, including coronary heart disease death, non-fatal MI, ischemic stroke, or unstable angina, there was a significant 15% relative risk reduction and a 1.6% absolute risk reduction. So a second PCSK9 inhibitor showing the same benefit, now in a more acute population. And I think what people had been looking for from Fourier, although the duration of follow-up was not long enough to show it, was that does this type of intervention, this intensive lipid lowering, reduce all-cause mortality? We do like to see all-cause mortality in a group of patients whose primary cause of death is cardiovascular. And just to remind you that Fourier was about a 2-year study, and so of course not powered to show reduction in all-cause mortality. Well, here the benefit of Odyssey is it went on for about 4 years. And as you can see here, looking at all-cause mortality, there was a statistically significant 15% relative risk reduction in all-cause mortality, or a 0.5% reduction in absolute terms. So these therapies do reduce all-cause mortality if you follow people long enough, and certainly for most of our patients, we're going to intend to treat them for years, not just 1 or 2 years. So PCSK9 as a mechanism is effective. We know that if you modify it through antibodies, the newest mechanism that has really generated exciting data is blocking PCSK9 synthesis. So not just having the protein out there and having the antibody to destroy it, but block it in the synthesis stage. And that can be done through a mechanism called RNA interference. And there is a drug called inclisiran, which harnesses a natural catalytic process. It has a modified, it's an oligonucleotide. It's modified so that it's picked up in the liver. And it's also modified so that it is prevented in terms of RNA degradation. So it sticks around for a long time. It incorporates into a RISC here with an RNA-induced silencing complex. And it degrades the mRNA of PCSK9 and halts protein synthesis in the liver. So they've developed this molecule which is targeted to the liver, which is protected from degradation, so it sticks around for a long time, and that blocks the generation of PCSK9. So it really achieves the same goal as evolocumab and alurocumab, but instead of doing it through an antibody, does it through RNA silencing. So if we look here at the effects on LDL lowering, this was presented by Dr. Ray at the ESC in 2017. Here they looked at people over a year. They looked at an initial injection of 300 milligrams and then a second injection at 6 months. And you can see profound and durable reductions in LDL cholesterol. Here with the 3 doses, but 300 milligrams resulted in an initial 50% reduction and then a 38.6% reduction. So a very durable reduction with a single dose of inclisiran. And I think this is quite striking, right? Instead of an injection every 2 weeks or every 4 weeks, we're talking about one injection over the course of the year. People ended with a 19% reduction. Certainly if you did it twice a year, you'd have a durable effect. You know, if we think of the issues we have with adherence to pills, patients complaining about having to take multiple pills a day, the idea that you could give someone an injection once or twice a year and achieve low LDLs is quite attractive. Here's the 2-dose regimen where you have durable reductions out to 30% reduction at 360 days. So this is a very exciting compound, and it may change the paradigm even when we think about primary prevention for LDL lowering. That you could imagine, Dr. Bromwald has raised this, where you could mix your inclisiran with a flu shot in a even lower risk or younger population, right? And you could lower the population's LDL significantly and reduce cardiovascular risk. So this is being studied. There is a trial now called Orion 4, a collaborative trial with the Oxford group and Tinney group. Will be a large trial looking at whether this strategy with 2 injections over the course of the year reduces cardiovascular outcomes. And this is potentially a much lower cost therapy than the antibodies. Okay, so translation into practice, I'll just spend a few minutes on this. Guidelines are recommending now non-statin therapy for patients that are unable to achieve their targets, such as ACS less than 70. And then the new outcomes trials have shown that lower LDLs are even better. I mean, if you can get someone to less than 30, it's even better and it's safe. If you look at real-world cohorts, and I didn't have time to show a lot of these data, but if you look at how we're actually doing in practice, we're nowhere close to the trials if you look at achieved LDLs in real-world populations. If you look at patients with peripheral artery disease, even in trials, there's a trial called BEST CLI looking at patients undergoing intervention for critical limb ischemia. The rates of statin use are not what you would hope. And if you look at broader real-world cohorts of MI patients, stroke patients, we're not achieving anywhere near the placebo group LDLs. And so how do you translate the data, which I'm showing you, which is get everyone down less than 30, to the real world where we know patients need to pay for drugs, they need to be willing to take them, they've got a bunch of other things to deal with. So how can you deal with this? And one idea is that do you risk stratify and select those subgroups at the highest risk? And so I tried to show you patients with diabetes, patients with high-risk MI, patients with peripheral artery disease. There are efforts to provide more rigorous ways of risk stratification. One of those has been from the Odyssey trial, which looked at, can we just use the LDL to risk stratify? Now in Fourier, the benefits were consistent regardless of where you started. But in Odyssey, they saw an interesting signal, and it was really the patients that had an LDL cholesterol greater than 100 that derived the greatest benefit. And I think in terms of absolute risk reductions, you would expect to see this. I think that the relative risk should line up. But if you're looking at ACS patients, who would you select? I think saying those who have a higher LDL on statin therapy are going to get a greater benefit is quite intuitive. So you could use LDL cholesterol as Gabriel Stegg sort of advocated for in his Odyssey presentation. Another way is to risk stratify based on the patient. And this is work done by Aaron Bahula and Dave Morrow in our group. Here they developed a secondary prevention risk score for patients just like the Fourier patients based on a simple algorithm. You get 1 point for each of these things. And if you use Chad's VASC for AFib, this will look quite similar. There's a lot of overlap here, but heart failure, hypertension, age, stroke, multivessel disease or CABG, PAD, smoking, and renal dysfunction. And you see a clear gradient of risk based on the number of risk factors you have. And here they stratified low, intermediate, and high. And if you look at the benefits of adding ezetimibe, you can see that there's a clear gradient of benefit too. And there's actually a statistical interaction here for the risk score. So that in patients that had the highest risk, those that had 3 or more risk factors, there was a 6.3% absolute risk difference, and almost 20% relative risk reduction. So one approach might be, if you can't prescribe it for everyone, to use a risk score like this to say, if you have 3 or more of these risk factors, you're going to benefit from adding ezetimibe or additional LDL lowering. And when that was applied in the Fourier trial, you see the exact same relationship. So here, if you had a high risk, here it was greater than 5, you had an absolute risk reduction of about 3.6. So risk scores, absolute LDL, or you might, what I do in my clinic is I recognize that the patients that have polyvascular disease and diabetes are those that are going to be at the highest risk, and I generally select them preferentially for treatment. Okay, so I want to leave 10 minutes or so for questions. Let me just summarize. LDL cholesterol can be reduced to unprecedented low levels with the combinations that I've talked about: statins, ezetimibe, and PCSK9 inhibitors, soon probably inclisiran too. Low LDL cholesterol with evolocumab and alirocumab, while on a statin, safely reduces cardiovascular risk, mostly by reducing MI and stroke, but Odyssey shows us that this translates into reductions in cardiovascular death and all-cause mortality. There was no excess in safety events, including diabetes and one of those robust neurocognitive studies that we've seen. And this is, in general, looking at the trials, that based on the totality of data, one would advocate for targeting LDL cholesterol levels very low, 20 to 25 milligrams per deciliter or lower in your higher risk patients. Obviously challenging to achieve, but something to strive for. And here's that New Zealand white rabbit that Bob likes to add to his slides here. And this is a little bit repetitive, but I think high intensity statin therapy is not enough. We still